All right, future nurses, welcome. Today, we are diving deep into pancreatitis. We're going to break this down so you absolutely master it, not just for your exams, but for when you're at the bedside making those critical, real-time decisions. So here's our game plan. We'll start with the why, the fundamental problem behind pancreatitis. Then we'll get into the what, how you're going to assess and care for your patient. And finally, we'll put it all together with some NCLEX-style questions to really make sure this knowledge is locked in. So let's get right to it.
Okay, first things first. What is actually happening inside a person's body when they have pancreatitis? Because to really get a handle on how to care for these patients, you have to understand the core problem.
I want you to lock in on this one single concept, autodigestion. Just think about that for a second. The super powerful enzymes that the pancreas creates to break down your food, well, instead of waiting to activate in the intestine, they flip on inside the pancreas itself. The organ literally starts digesting itself from the inside out. It's a brutal process that kicks off a massive inflammatory storm.
And listen, this isn't some rare thing you'll only read about in a textbook. We're talking over 250,000 cases every single year in the US alone. So yeah, you are going to see this. You're going to be the one taking care of these patients.
Now, it's really important to know the difference between the two main types. I want you to think of acute pancreatitis as a sudden, explosive wildfire. In contrast, chronic pancreatitis is more like a slow, smoldering burn that just keeps going over time, causing scarring and permanent damage to the organ. So, how do we spot this wildfire when a patient comes through the door? This next part is all about being a clinical detective, recognizing those key clues and symptoms that are screaming pancreatitis. Your assessment always starts with the patient's history. Now, gallstones and alcohol use? Yeah, those are the two biggest culprits for sure. But you can't get tunnel vision. You have to be asking about recent procedures, especially in ERCP, and also look into their medications and smoking history.
This is what you need to listen for. The pain of pancreatitis is, well, it's unmistakable. Patients will often describe it as a boring pain, like something is drilling straight through their abdomen to their back. That very specific description, location, and the fact that it radiates, that's a massive clue.
Next, you've got to do your physical exam. You're looking for bruising on the flanks or around the belly button. Those are really late, serious signs of bleeding. You're feeling for a rigid, board-like abdomen, looking for any yellowing of the skin, and listening for bowel sounds. Plus, you have to be on the lookout for signs of low calcium, like muscle twitching. We'll connect the dots on why that happens in just a moment.
And then the lab results come back, and they're what really confirms your suspicions. It's like the body is telling you a story. Amylase and lipase are sky high because pancreatic cells are literally bursting. White blood cell count is up, which signals major inflammation. Glucose is high because the pancreas is too damaged to produce enough insulin. And remember that low calcium we just talked about? Well, here's why. It's because of something called fat necrosis. Calcium gets all used up binding to fatty acids in the damaged tissue, basically pulling it right out of the bloodstream.
Okay, and here is a fantastic, high-yield NCLEX tip for you. A little memory anchor to help you on your exams. When you think pancreatitis, just remember this. The ACEs are high, just like aces in a deck of cards. That means amylase and lipase are going to be elevated. It's a super simple way to lock in two of the most critical diagnostic markers.
All right, so we know what the problem is. We know what's going on. Now for the big question, what in the world do we do about it? This section is all about our nursing actions, the interventions we're going to use to manage this and support our patients. If you remember absolutely nothing else from this section, please remember this. The single most important goal, everything we do revolves around this one thing, is to rest the pancreas. So how exactly do you give an organ a break? Simple. You stop asking it to work. That means the patient goes NPO, nothing by mouth, period. This completely cuts off the signal for the pancreas to release those destructive enzymes. Then, once the inflammation finally calms down, we can carefully start to reintroduce food, starting slow and easy with small, frequent meals that are bland and low in fat.
But it's not just about diet, right? We are juggling a ton of things here. We're aggressively managing their pain, which is often severe, usually with opioids. Positioning is also huge. Just having them lean forward can bring a lot of relief. We're on high alert for fluid shifts, which means we're constantly monitoring them and pushing a lot of IV fluids. And of course, education is a massive part of our job to help prevent this from ever happening again.
Now let's zoom in on the specific tools we have in our toolkit. This section covers the key medications and procedures that help us support the patient
manage their symptoms, and hopefully treat the underlying cause. So, for pain, we're using opioids. For those really severe necrotizing cases, we bring out the heavy-hitter antibiotics like imipenem. We'll use things like H2 blockers and PPIs to decrease stomach acid, which gives the pancreas even more of a rest. And for our chronic patients, pancreatic enzymes are absolutely essential. For patients with chronic pancreatitis, this medication, pancrealipase, is a total game changer. It's not just another pill. It replaces the enzymes their damaged pancreas can't make anymore. But here's the catch. It only works if it's taken correctly. And that's where your patient education is absolutely vital. They have to understand it must be taken with every single meal and every single snack. Sometimes the problem is mechanical. It's a plumbing issue, right? If a gallstone is literally plugging up the works, a procedure called an ERCP might be done to go in and get it. If the gallbladder is the source of all the stones, it might need to come out completely. All of these procedures are aimed at fixing the underlying structural problem. Okay, now we need to talk about the really dangerous stuff. Pancreatitis can go south, and it can go south fast. This is where you need to bring your sharpest assessment skills and your absolute highest level of clinical vigilance. The biggest, most immediate danger is hypovolemic shock. That massive inflammation makes blood vessels incredibly leaky, causing huge amounts of fluid, I'm talking up to 6 liters, to just pour out of the bloodstream and into the surrounding tissues. They call this third spacing, and it can cause a patient's blood pressure to plummet and their circulation to collapse. It is a true medical emergency.
You're going to hear two terms thrown around, pseudocyst and abscess, and it's critical you know the difference. A pseudocyst is basically a walled-off collection of fluid that's outside the pancreas. An abscess is a pocket of pus that's inside the pancreas. Both are really serious, but knowing which one you're dealing with is key.
And this is the absolute worst-case scenario. When that autodigestion is so severe that it causes widespread tissue death and bleeding, that's necrotizing hemorrhagic pancreatitis. Necrotizing means tissue death. Hemorrhagic means bleeding. This kicks off a massive body-wide inflammatory response that can shut down the lungs, the kidneys, and other organs, leading to multi-system organ failure.
Whew. Okay, you've just absorbed a ton of information. But now for the most important part, actually applying it. Let's see how all these concepts come together in the kind of questions you're going to face on the NCLEX and in your real-world practice. Here we go. First question. Think back to that slide on lab values. Which one of these findings are you expecting to see in a patient with acute pancreatitis? Go ahead and pause here if you need to and lock in your answer.
The correct answer is D, increased blood glucose. Let's walk through why. We know the ACEs, amylase and lipase, are high, not low, so A and B are out. And we know calcium is decreased, not increased, because of that fat necrosis, so C is out. That leaves us with high blood glucose, which makes perfect sense because the damaged pancreas can't produce enough insulin.
Okay, next up, a question about medication administration. Which of these actions is the correct one when you're giving pancrealipase? Let's apply those really important client education points we talked about. And the correct answer is B, offer a glass of water. Remember, you never, ever chew the capsule. You always take it with food, not before, and you sprinkle it on non-protein foods, and peanut butter is a protein. See how they test those little details? They're crucial for patient safety. All right, for our final slide, let's put you right there at the bedside with a clinical judgment scenario. Your patient with acute pancreatitis has been NPO for 3 days. Now they're telling you their pain is gone, you can hear bowel sounds, and they're looking at you saying, "I am starving. Can I please have something to eat?" So what is your priority action in this exact moment? What piece of the puzzle are you missing before you can safely move forward? This is exactly the kind of clinical judgment you'll be using every single day as a nurse. Think it over. We'll see you in the next one.